Welcome to the 14th Neonatal Resuscitation Symposium and Backtrack Section G. To join us at the Nicholson Conference Center on the campus of the University of Oklahoma Health Sciences Center. On behalf of the College of Medicine Department of Pediatrics and I want to welcome you to what has been an arduously planned, resilient journey to get today. It's 2 years worth of work after having to cancel last year's conference due to the COVID-19 pandemic. To be here standing in front of you, in front of those who have come from far away, be here in person to the discussants and be here in person. And importantly, to help to those who've been able to join us online. People are grateful to the steering for seeing this coming together, working so diligently when it looked like to be flexible enough to reflect. I want to thank the participants who have taken the personal risk to make the choice to be here in person, and for those who are unable to do so, for joining us virtually as well. I want to highlight the business and administration team in the section of the Airway as their tireless work. We continue to have as they host this new format. And most importantly, I want to thank those who have planned so hard, so not only in the United States, not only in North America and South America, achieve
I'm a professor emeritus here at Oklahoma University, and I'm long been involved with resuscitation from its inception in 1987, I think, and so the resuscitation, along with many other people in this conference and around the world. Resuscitation Symposium. We're especially happy as the chance to welcome people from around the world and across the United States. We as neonatologists are really privileged, along with all the other neonatal care providers, to intervene and in the life of every person, the birth, and of every family. And I think by your attendance today, you are demonstrating your passion for making that presence better, be more informed, and up to date. We want to be skilled and as caring as possible. This symposium brings together a group of people who are the best of the group that is most passionate and interested in this endeavor. We'll focus on the science, the education, and the clinical practice of neonatal resuscitation, because we know that the knowledge and skills that we have to bring to the delivery are the tools that serve. And with education, we really put those tools in so many other hands. And the research that informs what we do really hones those skills to a higher degree on every year, every occasion, every discovery. So with all this in mind, I hope that you enjoy today, that you're inspired and affirmed and lifted up in our endeavor to help babies in our practice and around the world. So our speakers today are going to really address those areas of science, applied practice, education, and organization and process to bring this knowledge and skills to people around the world. So I'm going to turn it over now to Edgardo, my co-host for the symposium today. Edgardo?
Thank you, Marilyn, and thank you all for being with us. Before I introduce our first speaker, there's some housekeeping. I want to welcome our virtual audience and ask them to start preparing their questions and send them by chat. We have two coordinators here trying to coordinate your questions, Dr. Song and Michel Blanc. And they asked me to let you know that I have a Twitter account and a hashtag account that is NewSAS 2021. Please join us there. And with that, I have the privilege. First of all, I need to introduce myself. I'm Edgardo Schill. I am the research director here at OU, coming from Argentina 7 years ago. And I am a current co-chair of the writing group for the North American recommendation for American Heart Association and the AAP, having participated in the ILCOR task force for more than 15 years. And this is my privilege to co-host this symposium with Dr. Escobedo. And this is my honor to introduce Dr. Peter Davis. Peter Davis is the professor of neonatal medicine at the Royal Women's Hospital in Melbourne. He completed his neonatal fellowship training in McMaster University, Canada, where he developed an interest in clinical epidemiology and evidence-based medicine. His interest in non-invasive ventilation led to an MD through the University of Melbourne in 1998. He leads a team of enthusiastic clinical researchers interested in improving the care of babies in the delivery room and in the intensive care units. I can witness that. And he's a substantial contributor of the Cochrane collaboration and a member of the neonatal subcommittee of the ILCOR. This is a short summary that he provided to me, and I will say that this demonstrates how humble is Peter, because it tried to summarize more than 300 publications. His CV is populated with more than 250 sheets, and I will say that I met Peter more than 20 years ago, and he's one of the smartest and humblest person I ever met. So I will thank you, Peter, for joining us so late at night from Australia. We would like to have you here in person, but it's fantastic to have you anyway, virtually. Thank you.
Thanks very much, Edgardo. Can I just check that everybody can hear me?
Clear.
That's great. And you can see my slides okay?
Yes.
Thanks very much, Sarah. So thanks, Edgardo. Wonderful to be with you. And as you say, it will be much better to be with you in person. I see you've managed to get a huge audience to this meeting, and it's a privilege to be part of the faculty. I wish it wasn't so late at night and I could stay and watch all of my friends talking tonight. We shouldn't start without acknowledging this is the week to celebrate the career of Marilyn Escobedo. And it's just been an absolute privilege working alongside her at ILCOR for some time now. Always the quietest but most convincing voice in the room. We thank you for your contribution to neonatology generally, and particularly to neonatal resuscitation. So tonight I'm going to be talking about the establishment of functional residual capacity during that transition from fetal to neonatal life. And let's start by acknowledging the contribution of my friend Stuart Hooper, who's a physiologist who's really helped us understand what it means to make that transition, particularly as it pertains to the aeration of the lung. Now, we've all read the textbooks, but Stuart's helped put this into perspective. We read in the textbooks that airway liquid clearance is due to three main mechanisms. The first is sodium reabsorption. So sodium is transported across the alveolar wall and drags water across with it. Yes, that happens, but it's a very slow mechanism for clearing lung liquid. It doesn't really help the baby in the first minutes of life. Secondly, we were taught about the importance of the vaginal squeeze as the baby is delivered. And again, Stuart would tell us that, yes, that plays a role. The posture-induced increases in transpulmonary pressure with every contraction of the uterus does get rid of some fluid, but again, quite a minority of the fluid. The most important mechanism is that increase in transepithelial pressure generated during inspiration. And he's given us this nice little graphic that shows the fetal lung filled with lung liquid in the moments before birth, and then with the first breaths of life, that fluid is driven down the airways through the alveoli and then into the interstitium of the lung. At any point, this fluid threatens to rush back into the lung and interfere with the transition, but with continuing respirations, then that fluid is driven into the interstitium, ultimately cleared from the lung, and normal breathing begins. And my friend Ayan Tapas, also a contributor to ILCOR, did some very interesting work when he was with us in Melbourne. All Ayan did was place a mask on a newborn baby's face. Attached to that mask was a respiratory function monitor, a hot wire anemometer, which monitors flow, and flow can be integrated into volume. So he could see what the babies were doing, flow going towards the baby above the line here, and then flow coming back from the baby below the line. So just by observing what babies did in that first few minutes of life, Ayan taught us a little bit about the characteristic patterns of breathing. The first pattern I draw to your attention is what he called the normal pattern. This is the way you and I breathe. We inspire, flow comes in, no pause at the end of it, inspiration, we breathe out straight away. And then there's a small expiratory pause, before we breathe in again, breathe out, little pause, and then breathe in again. That's what you and I are doing right now. But for newborn babies, this is quite an unusual breath, particularly in preterm babies. Much more commonly, Ayan observed this pattern of breathing, which he called braked expiration. So again, looking at the flow wave, you can see the flow goes into the baby takes a breath, but then holds it, and then breathes out. And straight away at the end of expiration, breathes back in again, holds it, breathes out, and breathes in straight away. So this baby is trying very hard to keep air in the lungs, keep those lungs open, drive the fluid out, and establish that functional residual capacity. There's some variance on that pattern, and the next one that we can see is crying and grunting. So the baby breathes in as before, and then lets out a little bit of air, stops, and then lets out a little bit more before taking another breath, and then a grunt, and then inspiration again. So all of this designed to keep gas in the lungs and maintain distension of the lungs with gas rather than fluid. Just draw your attention to this little notch on the expiratory limb of the volume. So volume going in, volume comes out, and a little glitch there. And we'll come back and talk about that in a minute. And this is my favorite observation of a baby really trying to inflate their lungs. We start at expiration, baby breathes out, breathes in a little bit and holds it, then breathes in a little bit more, holds it, breathes in a third time, holds it, breathes out, and then starts again. This is a baby working very hard to develop a functional residual capacity. That work was done about 10 years ago. Just in the last month or so, my friend David Tingay has published with us this more detailed imaging of the newborn transition. And what he's used is electrical impedance tomography, EIT, to image those first breaths of life. And this involves sighting 32 electrodes around the baby's chest, held on by a Velcro belt. And that EIT system is taking 48 frames per second images of the lung. As well, we were recording both sound and vision to help us time the events as they were going along. This enabled us to see the changes in lung volume throughout the respiratory cycle. So this was one of the patterns we saw: inspiration, expiration, inspiration again, and the functional EIT recording showing at the end of inspiration full aeration of the lungs. And at expiration, the lungs lose lung volume, or the lungs lose gas volume. The next pattern that we observed was this crying pattern. And so baby inspires as before, but halfway through expiration, a little pause, and then expiration continues at a slower rate than it did initially. Again, we see this notch, and the notch I drew your attention to on Ian's recordings, we see again here in the EIT images. The other thing that we should notice is that the filling of the lungs with gas is not uniform. In this case, the right side of the right lung is filling at greater volume, and it's doing it faster than the left lung. The next thing we can see is that with each successive crying breath particularly, there's a little gain in residual volume. So more gas is going in than coming out. So with each successive expiration, there's this little gain in volume, establishing a functional residual capacity. So two patterns: the cry breathing pattern. This one was taken at 25 seconds, so early on in a baby's life, and the regular tidal breathing pattern, in this case seen at 5 minutes, so somewhat later than those initial breaths. This superimposes quite nicely on Stuart Hooper's original images of how lung fluid is cleared. We can imagine, again, the lung filled with lung liquid right down the airways into the alveoli at the start of inspiration. The diaphragm contracts. We see inspiration, gas goes into the lung, drives the fluid down, and then expiration starts. Some fluid tries to return into the alveoli. And then there's this moment halfway through expiration during a cry or a grunt when the glottis closes, the diaphragm breaks, and there's this redistribution of gas from the aerated to the unaerated alveoli. And finally, the expiration is completed. The glottis opens, the diaphragm rises, and gas is expelled from the lung. Some fluid tries to re-enter. So this pattern of redistribution of gas is, we could call a form of pendullift from the well-aerated to the less well-aerated lungs. So this was a fairly small scale but very detailed study of 17 babies, more than 1,000 breaths. And the observations here, and they're just observations, are that there was a stable functional residual capacity established after about 43 breaths on average, but a lot of variation between babies. We noticed that the breathing patterns changed from predominantly crying, about 80% in the first minute, to tidal volume by about the 6th minute. The other important observation was that from birth, in the early stages, tidal ventilation is not uniform within the lung, favoured consistently the right lung and the non-dependent regions. We noted this pattern of initial crying. It's a unique pattern with delayed mid-expiratory pausing of gas flow associated with volume redistribution, that pendullift flow, and the establishment and the maintenance of functional residual capacity. So The commencement of air breathing at birth generates unique flow and volume states associated with marked ventilation inhomogeneity. And this is unique and very interesting, I think, to other respiratory physiologists. At birth, babies have this braking expiratory flow to defend functional residual capacity gains and redistribute gas to less well-aerated regions. So babies left to their own devices do very, very well at clearing fluid from their lungs and establishing a functional residual capacity and commencing ventilation. So we've made some attempts to replicate their success using the knowledge we've gained from physiological studies to apply to babies. With mixed effects, I think you'd have to admit. Start with the case of sustained inflations. And here I'd like to show you a video of a rabbit lung experiencing a sustained inflation. So this long, slow inspiration causing gentle aeration of the lungs continues for about 15 or 20 seconds up to full lung volume, and then ventilation can start. The functional residual capacity is established, and this premature rabbit is off to a flying start. Now, we at ILCOR looked at this question of sustained inflations back in 2015 as a promising development. The thought was that with the rapid establishment of FRC, that might improve outcomes following resuscitation. And we noted strong evidence from animal models, particularly the lamb and the rabbit, that suggested that sustained inflations were safe and effective. At that stage, there were 3 fairly small randomized trials and 2 cohort studies, and put together, they showed no benefit in terms of the important outcome of mortality. Also, no improvement in bronchopulmonary dysplasia, but likewise no risk of air leak. There was some evidence that the sustained inflations were doing some good in that there was some low quality evidence that they decreased the need for mechanical ventilation. And so the treatment recommendation from ILCOR at that stage was a gentle one. We suggest against the routine use of initial sustained inflation for preterm infants without spontaneous respirations. But we may consider them in individual circumstances, particularly in research settings. And this is a weak recommendation based on low quality evidence. The values and preferences that guided this recommendation were the absence of long-term benefits and the lack of clarity on how to administer a sustained inflation. And we noted at that time that there was a large randomized trial just beginning. So just turn to that trial, the SAIL trial. And the rationale for that was that, yes, if we got gas exchange started quickly, then we might have more effective resuscitation and hopefully better outcomes, based on the physiology that liquid-filled lungs would have a longer time constant than gas-filled lungs. So we probably should be adapting our short eye time intermittent positive pressure ventilation. You might expect a benefit if we had a longer, slower inflation. We noted the animal experiments that showed that sustained inflations were effective, but we also noted the differences between the animals and the babies we look after, in that the animals were intubated and sedated, not like our babies who we were ventilating through a mask and by and large were not sedated. We did it at the time because there was limited human experimental data, and there's this sort of global equipoise, if you like. The Europeans had embraced sustained inflation, the USA had not, and ILCOR, as I've said, was sitting on the fence. So the hypothesis underpinning the SAIL trial in PICO form was that our patients, babies between 23 and 27 weeks who required positive pressure ventilation, intervention with a sustained inflation, starting with 20 centimetres of water for 15 seconds and repeated at a slightly higher pressure if the first was not effective, was going to be better in comparison with conventional NRP style resuscitation with intermittent positive pressure ventilation with PEEP, and that it would improve outcomes, particularly the primary outcome of death or bronchopulmonary dysplasia at 36 weeks gestation. We did a sample size calculation, and with the conventional parameters showed that we'd need around 600 babies to show an important difference between the new and the old treatment. We had a very well constituted external monitoring committee featuring John Catwinkle and Alan Jobe, who you, I think, will agree are the leaders in our field. So we were in safe hands there. And they recommended to us after their third safety review that we stop. We should stop because they'd seen excess deaths in those first 48 hours in babies exposed to sustained inflation. This trial went ahead with consent taken in two ways: antenatal, which was done in all centres, and deferred consent, which was available in some of the non-US sites. And that's an interesting concept in resuscitation research. These were the sorts of babies that we were enrolling. As you see, slightly more than 400 of them. About half, slightly more than half, were consented using antenatal consent. Very high antenatal steroid usage. About 2/3 of our babies delivered by caesarean section. And these are the babies you'll see in your intensive care units, birth weight around the 700 gram mark, and a reasonable sprinkling of multiple pregnancies. So the primary outcome, no statistical significance in either the primary outcome or its components, death and BPD. If anything, it was favouring the control group, and most of the difference was explained by a reduction in death, 21% in the sustained inflation versus 16% in the control group. Emphasising again, none of these values was statistically significant. Some interesting secondary outcomes. We'd hoped that with sustained inflation, fewer babies would require intubation in the delivery room. So working from the bottom up, no evidence that that was happening. No difference in the need for chest compressions in the delivery suite, and no impact on surfactant delivery, either in the delivery room or in the intensive care unit. Probably mute, thanks. So always when you do a big randomized trial, it's nice to look at subgroups within that overall population. And there was some interest in this. Was there any difference between how the consent was obtained? Did boys and girls behave differently? Was there any difference in the gestational age strata, or whether or not babies had been exposed to steroids? The p-value to focus on here is the p-value for the test of interaction, and no difference within any of those subgroups. There was a bit of speculation and a feeling that perhaps the Europeans, who were used to delivering sustained inflation, might see different results, might see a more effect from a sustained inflation than the Americans and the Australians, who were relatively inexperienced. But again, no evidence of that effect at all. Looking at the adverse events that we had pre-specified and the external monitoring committee was following, and I've highlighted here the one that stopped the trial, an increase in death in the first 48 hours after birth. That's a very marked difference, highly statistically significant, 7.4% in the sustained inflation group versus 1.4% in the control group. And so that's why the trial had stopped. No important difference in any of the other adverse events, severe IVH in particular. Somewhat reassuringly, no increase in rate of pneumothorax in the sustained inflation group, and no difference in the 28-day outcomes either. So the conclusions were that in extremely preterm babies requiring resuscitation at birth, 1 or 2 sustained inflations do not reduce the risk of BPD and death, but may increase early mortality. Very disappointing that we couldn't apply the physiology that we thought we understood to our babies. So I'm going to move on from sustained inflation to the more common and standard procedure, and that is mask ventilation in the first minutes of life, and ask the question, at least in my hands and at our unit, it sometimes doesn't work, just doesn't work. We think mask ventilation is an easy skill to develop and maintain, but just sometimes babies do not respond. I'd like to try and explain some of the reasons why that might be so. And going back to these respiratory function monitor recordings of pressure, flow, and tidal volume. So on top, we've got the red graph showing ventilator pressure. So this baby's being ventilated on 30 peak inspiratory pressure, a PEEP of 5. Gas flow goes in, that's flow above the line, and then back from the baby in expiration, inflation, and expiration. That flow is integrated to give tidal volume, inspiratory tidal volume, expiratory tidal volume. That's good mask ventilation, but unfortunately not a terribly common recording. There's a number of problems with mask ventilation. One of them is leak, but the one I'd like to focus on today is airway obstruction. So again, looking at the pressure reading, see, that is going along perfectly fine. We've got a pressure of 30 on 5. If you were looking at the manometer or your pressure gauge in the delivery room, you would think you're doing a great job. This baby is being ventilated very effectively. However, if we look at the flow and volume traces, we see that there is no flow going either towards or away from the baby, no volume going into the baby. So we are not effectively ventilating this baby. George Schmaltz examined a series of our resuscitations in Melbourne and found that if we define airway obstruction as a 75% reduction in expired tidal volume, that's quite a severe reduction. This is occurring in about a quarter of our resuscitation, so quite a common problem. We always worried, what was the cause of that? Was it people putting the mask on too tightly to the face, or maybe just getting neck position wrong? Hyperextending or perhaps flexing the neck and causing obstruction at the airway level. Once again, Stuart Hooper's group has given us, I think, some answers about why we might be seeing this pattern. He's used a preterm rabbit model and used face mask ventilation immediately after birth, and then again, once a ventilation is well established, an hour after birth, and imaged what's going on with phase contrast X-ray imaging. So I'll just share that with you. We'll start with this image B, and here's the pharynx, here's the lungs, here's the trachea. And the pharynx is in continuity with the trachea. The glottis is open, the epiglottis is open. If you were to mask ventilate this rabbit, you would do a good job. This would be perfectly fine. This was not a common pattern in the first minutes of the rabbit's life. What Stuart's group observed much more commonly was obstruction. So the glottis is closed, the epiglottis is closed, so there's no continuity between the pharynx and the trachea. And if you try and mask ventilate a rabbit in this condition, then you will certainly aerate the esophagus. You won't aerate the trachea, and eventually you will aerate the stomach. And I think we all recognize times when we might have done that in the delivery room. So the explanation for this is possibly related to fetal development. And we remember from our fetal physiology that it's perfectly normal for the glottis and the epiglottis to be mostly closed during fetal life to allow lung growth. Having the glottis closed gives a buildup of liquid behind it and pressure that allows lung growth to continue throughout fetal life. These rabbit pups and our very preterm infants are really just exposed fetuses. In the rabbit model, they found that once the lung was aerated and regular respirations were established, the glottis and the epiglottis are mostly open, and then mask ventilation will work perfectly. In the animal lab, they made just some occasional observations that things that seem to enhance apnea and lead to unsuccessful mask ventilation. One was hypoxia, another was hypothermia, and the third was placement of a mask on the rabbit's face, and particularly if that mask was delivering a high CPAP pressure. And you might recognise some of the things that we see in our delivery rooms that might bear some similarity. This observation was taken from the animal lab back to the delivery room by, again, Ayante Pas and his group in the Netherlands, who looked at the effect of face mask application on breathing in preterm babies. And this was an observational study, more than 400 babies less than 32 weeks gestation. And his observation was that almost 90% of these babies were breathing before the mask went on. But once you put the mask on, about half stopped breathing. They noticed that this effect was greater as the gestational age decreased, and postulated that this is due to the trigeminal cardiac reflex. And it's stimulation of the sensory nerve endings of the trigeminal nerve that provokes breath holding and a reduction in heart rate. We did a similar study in our babies in Melbourne, and we did this in more mature babies, and our results were very consistent with the Dutch. So we're looking at babies more than 34 weeks. A proportion, not as great as the Dutch found, but a proportion stopped breathing when the mask went on, 10%, 10 or 11%. We noticed this was much more common the first time the mask went on, almost a third of babies versus 8% on subsequent applications. We also observed a drop in heart rate in association with the apnea. I'm just going to turn to another observational study done more than 10 years ago now by Colin O'Donnell when he was with us in Melbourne. And what Colin did was just went to 60 deliveries with his video camera and then observed what babies did in those first minutes of life. And what they are capable of, I think, surprises a lot of people. He noted that in these babies, less than 28 weeks, 80% of them are breathing and about 2/3 of them are crying. And even amongst the most immature, the 24 and the 25 weekers, 2/3 of them are breathing and more than half of them are crying. These babies are making a good attempt at establishing a functional residual capacity and beginning the transition to neonatal life. Can we help them do that? I'd like to finish by thinking a little bit about tactile stimulation to enhance transition. And all of our guidelines mention stimulation. We feel that it might help establish respirations after birth, but it is one of the most poorly studied aspects of neonatal resuscitation. Stimulation itself is poorly described in terms of how you do it and what are the effects of stimulating babies. Again, the Dutch have led the way here. They've examined tactile stimulation during stabilization of preterm babies, particularly babies less than 32 weeks gestational age. This is observational work. So this is starting at a very primitive level of working out what's going on. So they counted about 2/3 of their babies had any stimulation. In their hands, most of their stimulation was going on beyond the first minute of life and actually closer to 2 minutes of life. They're repeating that three times on average and a median duration of 8 seconds. The Dutch like to rub the soles of the feet. That was 2/3 of their stimulatory efforts. Things like rubbing the back and flicking the soles of the feet were less common. They did note an association between babies who did not receive stimulation and those who did. So those who did not receive stimulation were more than twice as likely to require intubation in the delivery room. Very much an association, but an interesting observation. We did a similar study in Melbourne, again, looking at video recordings of neonatal resuscitation. In Australia, we stimulate slightly differently. We counted the drying action as stimulation. We observed people rubbing the chest or rubbing the back or flicking the foot. And we documented the frequency and the infant response. So a couple of interesting things here. There was a difference in how we handled babies more than 30 weeks and less than 30 weeks. More than 30 weeks, yes, most babies were being stimulated. 90% of them were being stimulated in the first minutes of life. Whereas those babies less than 30 weeks, almost 2/3 of them had no stimulation at all during their resuscitation. This may have been due to people being reluctant to touch them once they'd gone into their plastic wrap. And then we noticed that the effectiveness in eliciting a cry of the different types of stimulation and things like the back rub and the chest rub seemed to be more effective than particularly the foot lick or just drying of the baby. So again, very primitive observations, but we're starting from a low base. Our conclusions were that less mature babies were stimulated less frequently compared to more mature babies, and many very preterm infants did not receive any stimulation. In our hands, it looked like rubbing the trunk might be the most effective way of stimulating a baby on eliciting a trial, but this needs to be confirmed in prospective studies. So what have we learned after several decades of trying? Well, we know now that newborn babies have unique patterns of breathing, which are very effective at clearing lung fluid and establishing functional residual capacity. Our attempts to replicate or take over this process are imperfect and sometimes do more harm than good. Stimulation is that great unexamined component of resuscitation. It's widely recommended, but remains the least investigated form of intervention in the delivery room. And perhaps recognizing which babies need our help, our serious help, mask ventilation, endotracheal intubation, and which need a gentle rub of their back, that's the big challenge. So I'm going to stop there. I'm going to welcome you all when the borders are open to come down and see us and enjoy our beaches. We are being deprived of American visitors for too long now. We'd be delighted to see you there. Thanks very much for your attention.
Thank you, Peter, for the fantastic presentation, very evocative. And I want to invite our audience virtual to send their questions or comments through chat. And I want to welcome Sarah Belderhammer and Sahus Kalapur, our discussant for this session. I introduce Dr. Belderhammer. He's an associate professor of pediatrics at the University of Washington in Seattle. She trained at the University of Washington for her resident followed by fellowship in Harvard Neonatal Experimental Programs. Her research interests include newborn resuscitation education, pulmonary and resuscitative physiology, and BPD. She has contributed to the understanding of newborn resuscitation in low resource settings, as well as contribution of mitochondrial oxygen stress in development and recovery of BPD. She has served as an editor for the Helping Babies Breathe Survive program and is a member of the former chair of the Helping Babies Breathe Planning Group and represents the section of neonatal perinatal medicine at the AAP's NC Planning Group. Dr. Kalapur is a professor of pediatric and chief division of neonatology and development biology at the UCLA. His medical schooling was in Mumbai, India, and then pediatric resident training was at Children's Hospital in Michigan and neonatology fellowship at Cincinnati Children's Hospital, where he stayed when he rose through the rank of becoming a full professor before moving to UCLA in 2017. His NIH-funded research is in perinatal infection and fetal inflammation and has contributed to the understanding of fetal lung injury, BPD, and fetal placental immunology. He has served on multiple NIH study sections as an invited expert for NIH workshop. We are honored to have both of these discussants as the program today. So welcome both of you and everybody to our discussion session. Our audience may ask the questions through, we have a circulating mic, and I will start with our panelists, please. Sarah?
Thank you. Thank you for the introduction. And Dr. Davis, thank you for an amazing talk. I love this talk. And So humbled and excited to be assigned as your panelist for many reasons. First, we have to thank you for being here. I believe it's 2 a.m. there, so I can't complain that I had to get up at 5 on the West Coast. So thanks for staying up late. We hope you have a good sleep after this. But I love this talk for many reasons. Wearing my global health hat and my long commitment to resuscitation in low resource settings, I love the concept of how much we don't understand about the simple and easy steps of resuscitation and how much you have taught us through your career. And in particular, one really fun part to it, and I have no doubt that some of my colleagues with HVB, in particular, Nalini Singhal and Susan Niermeyer, would have loved to have had you as an advocate in the challenge that we faced with coming up with educational programs with the WHO. So the collaborative efforts of incorporating HVB along with WHO's educational curriculum resulted in lengthy conversations about the baby who does not actually cry at birth, but is breathing effectively. And that if I understand the argument to it, that there are concerns that our stimulation of these babies is incompatible with our goals of respectful care. We don't need to be making babies cry, etc. And I just would love you to comment further about the critical role that crying actually plays in the baby's transitional physiology in terms of achieving FRC. You showed us that picture, but wishing that we could collaboratively, recognizing that there are millions and millions of babies who are resuscitated with algorithms produced by collaboratively with the WHO. This issue of us, it makes me cringe as a neonatologist to picture a baby who's not actually vigorous and breathing, crying at birth, that our comfort with saying those quiet babies who are breathing, where we see those infants. And I'm not sure if you had heard that debate heading into this, but it was a big one with the WHO in the past year.
I hadn't heard that one, Sarah. That's a really interesting point, isn't it? And yes, we do want to treat babies respectfully, and we certainly don't want to hurt them. But there's something, I think, hardwired into some of us that are very reassured by when we hear a baby cry, no matter what the gestation. If the baby's crying, then we can walk away, give the baby to the mother, and things are going to be fine. It's very difficult to tell whether a baby is breathing effectively. So those babies who are breathing quietly and who never cry would worry me that the maybe the chest might be going up and down. But perhaps there's not any gas going in and out, and just a small bit of stimulation for that baby, a couple of decent cries, and the baby opens up, the larynx starts to work in its proper way, and then the baby does very well. On the other hand, if the first response is to put a mask on this quiet baby's face and whatever breathing it was doing immediately stops, then you've made a bad situation worse. And I think I've seen that plenty of times, and even been called to the odd code blue where the fellow is frantically masking the baby, and the solution is take the mask off the face, give the baby a little bit of stimulation, get a cry, and you walk out a hero. That's that's not to say that mask ventilation is not called for in many situations. It remains our fundamental tool in helping babies, but choosing the babies who need it, using it in its proper place, I think is something we need to further investigate.
Thank you, Peter and Sarah. Suhas?
Yeah, sure. No, thank you, Peter. That was fantastic. I mean, I always admire your talks, but just the elegance of all the work from your group. I really want to give kudos to your entire group and to this body of knowledge, and understanding how. I mean, you probably never in your life have to face this problem of filling an airless chest with air, and that too in the first minute, and it's a do or die proposition. So it's really amazing when you think about the enormity of the task and how automatically all of this just happens. But just there are many questions, but I think probably the audience would be more interested in the more pragmatic issues. I have some more sort of research questions, but there is one question from the audience. Edgardo, are you monitoring, or should I go ahead and ask the questions? So one of the issues was, the issue of stimulation. You highlighted. There was a concern from somebody in the audience. Would that increase the rate of IVH, for example, vigorous stimulation in the first few minutes? Your thoughts?
Yeah, look, I think stimulation to the point of causing IVH is obviously too much stimulation. So, we as I said before, we must respect these babies and treat them gently, but it is possible to stimulate a baby gently. We're not having large movements, particularly of the head. We're gently rubbing the chest. I quite like the foot rub or the foot flick, something that's short and sharp, and we'll start the baby breathing. To the best of my knowledge, there's no connection between stimulation and IVH. So IVH, as best we can tell, is the major changes with in blood flow to the brain. And I don't think, I think a smooth transition is the best preventive for that.
Great. And another issue, Peter, is, you have beautifully told us how the transition happens in both preterm babies, but there are these antenatal conditions that leads to prematurity in the first place. Premature babies, as Alan reminds us always, none of them are normal. Alan Job always tells us, none of these preterms are normal. There is something that leads to prematurity. What do we know about these antenatal conditions? For example, growth restriction, for example, or antenatal inflammation, a transitioning of these babies when they're exposed to these prenatal conditions?
I think you're probably in a much better position to answer that question than I am, Suhas. I agree. Alan tells us not to lump all babies together. I think we just haven't reached that degree of sophistication where we can tailor our resuscitation. If we had Alan Job for another century, we might make some headway in that, to fine tune our resuscitations. But I don't think we're there yet. But it's a noble aim to understand the differences. I'm not aware of any differences in response for a big group of those babies, the IUGR babies, but it's something we should be looking at. Yeah. There
was, you may remember that Jane Pillow, in Perth, working with our group, etc. We have this sheet model of antenatal inflammation with, I know, Tim Moss at your place also, and Graham Polglaze, and all these people are doing. But Jane showed us that actually in this sheep model, antenatal exposure to inflammation actually had deleterious effects on the diaphragm. This is not something that we think about, and diaphragm is such an important muscle for all of the things that you mentioned, not only the first breath to generate those large negative pressures that are needed, but also for fetal lung fluid clearance and such. And I just think we need to pay a little bit more attention to the diaphragm and what things might affect and stimulate diaphragm, and just wondered what your thoughts are.
I can only agree with you, Suhas. I don't think I've got any other information to add to that you've just provided. That's very useful. Thank you.
The other population that comes to mind in your work, from my perspective, are the kids who are not necessarily neurologically intact. So our babies who have suffered asphyxia, and the description of the breaking, as well as the the normal respiratory patterns, how effective or how ineffective those may be when the babies are affected by asphyxia. But I have a feeling the audience may also be intrigued to hear thoughts on sort of novel concepts in resuscitation. A couple that came to mind were either, we know that Dr. Ram has described resuscitation with a ram cannula, maybe that avoids your TCR, or when you show those beautiful images by EIT of the distribution of the air. I mean, does anybody think of doing a left side up if you're not aerating that well enough? Or since we're dependent, should babies be rolled around a bit more during their early steps of resuscitation? And I think that those of us who have watched videos of resuscitations occurring in many different environments have seen that. There are places that do a little bit more aggressive movement of our babies. And any fun things that you see coming down the pipeline that we should all be thinking about as we venture further in resuscitation?
Well, I think as always, Dr. Ram is thinking very logically. We're having similar thoughts and moving into research projects addressing that issue of could we would use high flow nasal cannulae rather than his cannulae, but the principle is probably the same, to just give those babies a little bit of oxygen. And this has got to be sorted out. You know, that we've shown that in general terms 100% oxygen is a bad thing for babies if given throughout the resuscitation. It seems to me likely that a pulse of not necessarily 100% but additional oxygen given in a way that doesn't stimulate the trigeminal nerve might be a short circuit for those babies who are going on to become apneic and then in our hands not being able to mask ventilate them. So yeah, we're exploring that possibility of either placing high flow cannulae or nasal CPAP cannulae even while the baby's still on the umbilical cord, and then that gets them off, avoids the hypoxia, avoids the trigeminal stimulation, and we get a smoother transition. We didn't really talk about delayed cord clamping, and I saw a little bit of that in the chat. I think that's a very important part of the equation. I've talked about the lung as though it's in isolation, but clearly it's the lung and the heart work together. The lung needs to be aerated for the vascular changes to occur. If we leave the baby on the cord, that helps the vascular changes occur while the baby aerates their lungs. Maybe it keeps our hands off the baby a little bit in that first minute of life as well. So there's some important interactions there.
Thank you. Let me see if we have some questions from the audience. Yes, please, from the chat.
Yes, we have several questions from the chat. Let's start with our first one. Dr. Ringer and others have asked about crying babies. Does that create a PEEP, and is that better?
Yeah, it's the same. It's the same principle. I think, if I heard the question correctly, is crying the same as PEEP? But it's not exactly, is it? But it does give that protection against the loss of FRC. So when we were ventilating without PEEP, the pressure going down to zero probably promoted the re-entry of fluid at the end of expiration and made that transition slower. The addition of PEEP probably helps. The addition of crying helps, is sort of nature's own PEEP, crying and grunting, that sort of trapping of air halfway through expiration maintains the pressure, probably keeps the alveoli aerated and not fluid filled. So yes, there's some overlap there.
Thank you. Another question for the chat, please.
We also have several questions about your about the SAIL trial, and you mentioned a higher death in at around 48 hours. What was the cause of that?
I saw that question lurking from Myra Wyckoff, and yes, it's scary knowing the boss is watching your talk, isn't it? But very good question from Myra, as you would expect. Look, we did look at that, and the causes of death were the same as for all of our other extremely preterm babies. They were things like sepsis and neck and IVH, and there didn't seem to be any difference in the cause of death between the control group and the sustained inflation group. We didn't do quite as good a job as we could have had we anticipated a difference in death rate. And going forwards, I think we and others involved in resuscitation research are documenting deaths much more carefully, and we'll try and be able to do that better with subsequent trials. But as best as we could tell, there was no systematic difference in the cause of death between the control and the SI babies. And just to remind you that there was no statistically significant difference in death overall. It was the deaths in the early, just in the first 48 hours that was statistically significantly different. By the time the trial had finished, the control babies had almost caught up.
Thank you. We have more questions from the chat, from the audience.
Can I follow up on the sales, since that, first I do want to give a shout out to the UP group and Dr. Jaisari Nair, who did a really thoughtful evaluation in the sheep model of delayed cord clamping along with sustained inflation, and showed that it compromised pulmonary blood flow. And so I think that's quite relevant to our concerns about mortality, even if we don't see that any of the other outcomes in sales showed up as relevant. But one of them that I apologize, because I looked at it again, knowing your involvement, and read it again, that I couldn't understand and would love some explanation to, is that when they talked about bradycardia, there was a significant difference in the two cohorts, and they worded it as after the first maneuver. And did that first maneuver reference the actual sustained inflation versus PPV, what the heart rate was? Because that would be further evidence that in these tiny little babies, this could be compromising their hemodynamics more than we're appreciating.
Yeah, I'm sorry, I'm not able to answer that question directly. I suspect it may have just been a delay in starting effective ventilation, and that sustained inflation that we thought we were giving was blocked by the glottis, and all we were doing was delaying the start of effective IPPV by 15 or 30 seconds. So I'm not sure about the hemodynamic effects of the sustained inflation, but that's a possibility, something to be aware of.
Escobedo?
I have a quick question, Peter. Very interesting to talk about the stimulation and the fact that we haven't studied it very much. So it brought the question to my mind about, is it touch? I mean, what is the stimulation that's effective? Is it touch, which is a light touch and could be more or less? Is it proprioception, which I think Sarah mentioned about moving babies around? Or is it pain, like your favorite flick on the foot, which could be painful and perhaps is the correct kind of stimulation? So what do you think?
Yeah, very good question, and I really can't answer that one honestly. I think you would hope it was proprioception. You would hope that we have evolved so that the normal handling that occurs after birth is what represents normal stimulation, and perhaps a little bit more of that is what we need. You know, there are other things that seem to stimulate babies. If you blow on them, and you create that sort of temperature sensation that sometimes causes them to gasp and start breathing. Gentle rubbing, I think, is probably all that's required. But the mechanism, as I say, it's our understanding is quite primitive.
So one.
Yes.
This is Carlos Ramos from the University of California, San Diego. Thank you so much for your talk. It's excellent, and there's a lot of have given us a lot to think about. For me, one of the most interesting part was the how mass CPAP is more than 7 cm of water is causing apnea and is spontaneously breathing babies. And the reason why that is interesting for me is because the latest European guidelines for the prevention of RDS, they suggest to do CPAP of 8 in the spontaneously breathing babies. In the US, we're a little bit more conservative, at least for us, going to 6 in the delivery room was the biggest step. So what do you think? I mean, we're using CPAP in babies that are breathing. We're going up to 8, but now we have this data that can cause apnea. So it seems like we're working against ourselves. So what are your thoughts about that? Thank you.
Yeah, I may regret making that observation or relaying that observation. That reminding us that this is an observation in rabbits. Okay, in a limited number of rabbits. So I'd be reluctant to extend that to the human population. And I think there's a difference between the optimal amount of CPAP for those first breaths and the optimum amount of CPAP for a baby who's transitioned and gone on to develop hyaline membrane disease. For me, it's a matter of titrating the amount of CPAP to the baby's illness severity. How bad is the respiratory distress syndrome? How non-compliant are the lungs? And for those babies with established RDS or developing RDS, a CPAP of 7 or 8 doesn't frighten me. I think the initial CPAP, I'm not sure about, but whatever the CPAP is, if the glottis is closed, the baby is not seeing any of that pressure. So the point is that the baby needs to start to breathe before the CPAP starts. And perhaps, and this is speculative, don't go out and necessarily start practicing this in the delivery room, but the idea of putting a ram cannula on and hands away from the mouth might be a good one. I think that's something that we all need to look at.
Yeah. Thank you. Peter, have some other questions from the chat, please.
There's a question from Caroline Crocker. Do you have any thoughts on the benefit of jaw thrust for airway obstruction? We see anesthesiologists and others use this practice, but don't typically think about it for neonates.
Yeah, I think, well, we teach when you put the mask on that you need to support the jaw and provide a counterbalance to the downward pressure of the mask on the face, and that will give you a good seal. And so we're assuming now that the baby is the glottis is open, the baby's had a cry but needs some mask ventilation. So yes, jaw support rather than jaw thrust is the term I would use, but that's a reasonable thing to provide to the baby, and that's something we practice. I suspect if you do that badly, then that will not be helpful. But keeping the head and neck in the neutral position, some jaw support to counter the pressure of the mask, I think is a reasonable strategy.
Yeah. I have a question for you, Peter. Thank you again for a fantastic talk. You mentioned that 25% of the preemies, they show some glottis obstruction, and it's useless to provide pressure against that because we are not opening. There's some evidence for some of your former partner from the Ariantipas about oxygen. What would be your main recommendation of what is current knowledge about how to overcome this glottis obstruction? If you have a way to identify when the glottis is obstructed in preemie and how to overcome this obstruction without intubation.
Edgardo, I'm having trouble understanding that. Sarah or Suhas, could you?
I think Edgardo is talking about glottic obstruction.
Yes.
Correct. Yeah.
So he's saying the 25% that George Schmolzer identified, how much of that in preemies do you feel might be glottic obstruction?
Well, that's what I'm suggesting, that most of that is glottic obstruction. I think that's it fits. We now have an explanation for that. It's consistent with our observations. So I think for those babies, probably taking the mask off the face, giving some stimulation and allowing those babies to cry before trying to support them with the mask is probably the way to go. some of those babies will actually need an endotracheal tube, and you know, that we do need to be prepared still to do that.
There is a question in the chat, and I had that question as well, which is, you know, you highlighted the importance of spontaneous breathing and how that helps with FRC, but also fluid clearance and all that. And what are your thoughts on caffeine, very early caffeine? And one step further, you know, could you even give it to the mother in later stages of labor, for example? What are your thoughts?
Yeah, I think again, Suhas, very sensible physiologically based suggestions, and we're working on a late delivery of caffeine to the mother in labour, and seeing if that works. I know IAN has done some work with injecting caffeine in the delivery room through the umbilical vein with some success. And interesting to note that if you go back into the literature, caffeine was used as a resuscitation drug back in the 50s and 60s for that reason. When I talked to Stuart about this, he says, yep, that's probably going to be the icing on the cake, if you like, for really advanced settings that might just give a little bit more of an edge. But for the vast majority that Sarah talked about earlier, the thought of adding drugs to this mixture probably not such a good idea, at least until we have some more evidence. So still in the research category, I would have thought, rather than taking it along to your next delivery.
Thank you. We are on time to move to the next session. Thank you very much for all of you for your participation in the chat audience, and especially to you, Peter, for staying so late with us. So thank you all, and I pass the voice to Dr. Song to introduce our next speaker. Thank you.
Thank you. Bye.
Thank you.
Hello, everyone. My name is Claire Song. I'm a neonatologist from Southern California, from an NT Medical Group, and I currently serve on the exec committee for the American Academy of Pediatrics on the section of neonatal prenatal medicine. And I have the extreme pleasure of serving on this symposium's planning committee as well. I'd love to introduce our next speaker, Dr. Gary Weiner. He's an associate professor of pediatrics and director of the Neonatal Prenatal Medicine Fellowship Program at University of Michigan's Mott Children's Hospital. His academic focus has been on the development of educational materials and